Okay, good morning, everyone. Welcome to the Color of COVID-19 conversation specific to Connecticut. We are so excited to have this conversation. In preparation for this meeting, I have a couple of logistics that I'd like to take care of for you all. First of all, I'm Jody Hill-Lilly. I know most of you and excited to see your names and looking forward to the conversations and the chats. I am going to ask that you mute your lines. I repeat, please mute your lines and also turn off your video cameras. We're going to ask you to turn off the video cameras. Thank you. This will increase our ability to, this will maximize our ability to keep teams running. As you know, we've been experiencing some glitches with teams. Anyway, so welcome. We are excited about this conversation. We are going to be, as I said, using the chat box to interact with you all. And so I see you all practicing in there, and we're excited to see you all converse with one another and us. In preparation for this important conversation, I'd like to just for a moment center ourselves and be mindful of the fact that there are many of us in Connecticut, in the United States, and throughout the world suffering with this this pandemic event and with COVID-19. And particularly, we have a number of foster parents and even our own staff who have tested positive for COVID-19. Many of us have been to funerals and have lost, loved ones. Funerals are remote, as we know, and it's a difficult time. So I'd like to take a moment just to pause and have a moment of silence for those who have lost their lives and for those who are suffering with COVID-19. Thank you. Certainly, these are unprecedented times, and we are all trying to figure it out together. But we at the department understand that there is a larger conversation as to how this pandemic is impacting communities of color. So today, we have put together a presentation for you all in an effort to increase awareness of how COVID-19 is uniquely impacting communities of color. Today, we hope to highlight the relationship between historical racism, social determinants, racial trauma, and the impact of COVID-19 on communities of color. We will also be sharing DCF specific data on COVID-19 and its impact on communities of color and staff. We also, as leaders of this department, we are going to be looking to you to lead the charge so that we can change the trajectory of how this is impacting the families that we serve here in DCF. As you know, the Racial Justice Work Group has been hard at work over the years. We're very proud of that work in DCF, Connecticut DCF, and have been touted as leaders in the country in this conversation in the field of child welfare. As you know, you may know, this is a first of a series of conversations that we're going to have. It will serve to be foundation laying for the work of the Racial Justice Group. And we wanted to make sure that we were all having the same conversation about how COVID-19 is impacting communities of colors. So we look forward to this conversation. I wanted to bring to your attention the folks who have made this happen. Our Director of Multicultural Affairs, Monica Rams, whom you'll meet in a minute, our consultant, those of you familiar with Jenna Goldstein, who has been in partnership with us over the years in our work with the racial justice. I also like to acknowledge Tina Jefferson for her work in leading the racial justice work in Connecticut. And a lot of what is happening today is shaped by women and of course the executive team. Like to acknowledge them as well. So we would like to start off by welcoming our commissioner, Vanessa Durantes, for some opening remarks, and some welcome. Commissioner?
Good morning, everyone. Really great to see everyone, whether it's virtual or not. I'm excited not only to lead this department, but to lead the work that comes from this department. As one of the former tri-chairs of DCF Statewide Racial Justice Work Group, I'm excited to be able to think about the work that has been done since its establishment in 2013, and think about how our racial justice work group has stood the test of time. You know, there's a lot that still has to be done, but we certainly aren't where we were 20, 10, 15 years ago. So as I think about how we lead and guide and support the department and its work related to racial justice, I want to make sure that we do a little bit of level setting before we begin. Our first Racial Justice Summit was in 2016, and it focused on education inequities and the research of Yale professor Dr. Walter Gilliam about the role of implicit bias and expulsion rates of Black children. In 2018, we hosted our second Racial Justice Summit, which spotlighted the importance of external collaboration. And together with St. Joseph College and our statewide advisory council, we partnered to bring Dr. Kenneth Hardy of the Drexler University to have a deep-rooted conversation about the impacts of racial trauma. Since that time, DCF has continued to fill its toolbox with strategies to address disparate outcomes across multiple decision points across our agency. That brings us to today. We know the intersectionality of race compounds the issues that cause a family to become involved with DCF. This pandemic has gripped us internationally, and racial disparities have exacerbated and illuminated the concerns that we've had and we've known for quite some time. As Jody mentioned, our DCF family has also been impacted by this, by personal losses. And we've even had 30 DCF staff members who have tested positive. And so when we think about disparities and disparate outcomes, although we have a very diverse staff, the statistic of 22 of those 30 staff members being of color should be something that should give you pause. We'll be giving you additional DCF data from our very own attorney, Susan Smith, who will be helping us to dissect what the analysis of DCF data looks like over the last couple of months. Among the community at large and across Connecticut, we're learning how the concerns of this crisis has brought additional attention to racial inequities. And we are excited to bring to you one of the leaders of the heroes of the healthcare system that are helping to shepherd Connecticut through this. In a few minutes, you will hear from Dr. Reggie Neely, who is the president and CEO of Trinity Health Network. And then we will be able to have a question and answer session that will help us to do a deep dive into what this means when we say the color of COVID in Connecticut as it relates to children and families. We welcome you and we encourage you to roll up your sleeves and to take action, because today is just not about sharing information. It is about what we do next. So without further ado, I turn this over to our Director of Multicultural Affairs, Monica Montalvo-Rams, who will begin with the introduction of our keynote speaker.
Good morning, everyone. Thank you all for taking the time to join us this morning. We're excited to have you all here with us so we can talk about the impacts of COVID-19 on our communities of color. I get the distinct honor and pleasure of introducing you to our guest, Dr. Reginald J. Eady, who is the president and CEO of Trinity Health of New England, and I will be reading his bio, and then I will be turning things over to him. So without further ado, here we go. Reginald J. Eady, MD, is an accomplished and innovative leader in transforming healthcare and patient care to meet the needs of the 21st century. Born and raised in Detroit, Eady began his journey towards becoming a physician, a career goal he established at the age of 7. He is a board-certified emergency medicine physician. Dr. Eady earned his Bachelor's of Science degree with magna cum laude honors from South Carolina State University in Orangeburg, South Carolina. Following undergraduate school, he returned to Michigan to earn his medical degree from Wayne State University School of Medicine. In April 2008, he was named the Vice President of Medical Affairs at DMC Harper University Hospital, Hutzel Women's Hospital. 2 years later, he was appointed CEO at DMC Detroit Receiving Hospital, where he served as CEO from July 2010 through December 2011. He next served as a CEO of DMC Sinai Grace Hospital from January 12th through October 2013. During that time, he enrolled in the Michigan State University Broad Executive MBA program, which he completed in May 2013. This prepared him for his next assignment of serving as CEO of both DMC Detroit Receiving Hospital and DMC Harper Hutzel Women's Hospital from October 2013 through October 2015. His primary goal was to grow market share of both facilities while integrating them into a 900-bed facility. He began his final role as a Detroit-based healthcare executive with an appointment to the Detroit Medical Center Regional Chief Operating Officer in August of 2015. Dr. Eady and his lovely wife, Kimberly, left Detroit to join the Trinity Health of New England team as president and CEO in April of 2018. His community talents are not limited to medicine, as he published his first book in 2008 titled How to Eat and Live Longer. In the book, he uses his biblical and medical knowledge and experience as a weight loss physician for more than 10 years to address the health challenges facing inner city residents. His book has been listed on numerous bestsellers lists, and he has been featured in Ebony and Essence magazines and has been the guest on radio programs across the country. He has a soon-to-be-released second book titled Eating from the Tree of Life. Without further ado, here is Dr. Reginald J. Eady.
Thank you. And just as an IT check, can you guys see the slides?
Yes, we can.
Perfect.
Yes, sir.
All right. So before I get started, I just want to make just a few opening remarks. First of all, I'll begin by thanking the Connecticut Department of Children and Families, not just for allowing me to participate, but really for the important work that you're doing. The fact that you're partnering with healthcare communities like Trinity Health New England and empowering families to raise resilient children who thrive. So your work, and I think as a scientist does, it sort of reminds me when I think of resilience of the building of a muscle, right? So exercising and the muscle. Your resilience with your work, it doesn't only build strength within yourselves, but it builds strengths within each other and the communities that you serve. So thank you. Thank you to Commissioner Vanessa Durantes, Deputy Commissioner Jody Hill-Lilly, and Deputy Commissioner Michael Williams, and all other leaders on this line for keeping the faith. And then I'm a little premature, but I've got to leverage the opportunity to say Happy Mother's Day to all the mothers who are participating in the conversation. Interestingly, I had the opportunity to talk to my mother this morning and while driving into work, and we talked about sort of my day, and I told her I'd be participating in this very important conversation. And I just wanted to let you guys know of something that she said that I thought was very interesting. So she said, a virus to be so small could cause so much damage in our community, which is very interesting. She went on to say, if you think about faith being the substance of things hoped for and evidence of things unseen, then if we just had the amount of faith, even smaller than a mustard seed, but the size of this virus, I think together, DCF, we can do our part in mitigating the spread of this virus, particularly in the communities of color. And so while I come to you today as the CEO of Trinity Health New England, I speak to you instead as a physician and a community advocate. I also sort of speak to you with the resuscitated vocal cords of one of my heroes, the great Fannie Lou Hamer. If you recall in 1964, when she spoke to the Democratic National Convention, she said, "I'm sick and tired of being sick and tired." And today's conversation sort of reminds me of her and that. Today's conversation, I think, is a reflection of all of us being sick and tired of seeing people of color sick and tired. And so with that, why don't we jump right into some slides that I prepared to sort of navigate us through today's conversation. I thought I'd focus on 4 salient points in reference to the color of COVID. One being Connecticut's COVID-19, another being the Corona, while Black or Latinx, which is interesting to me. The essential worker being the third, and then the fourth is the why, right? So the why is this happening? It also will be a little controversial, and I'll talk about the pros, but I'll focus on the cons, I believe, around the stay-at-home campaign. And then, of course, we'll talk about some most textbooks call them social determinants of health, but I will refer to them as social influencers of health. Let's start with Connecticut's COVID-19, which, because of its proximity to New York, we, number one, had the opportunity to learn a lot from the city of New York, or two, we've had the opportunity or potential to become a hotspot, right? So we didn't see what New York saw, so that's all good news. But the message today is that we're still not out of the clear and could still find ourselves in such a similar situation. So it was on the 8th day of March when our governor announced that we had our first confirmed case of this novel coronavirus. And let me stress that it was our first confirmed case, because we at that time had many suspected cases. So the first case, if I recall correctly, was a 40 to 50-year-old who believed to have contracted the virus during a trip to the state of California. Just a couple of facts or reminders about this coronavirus. So it's called a novel coronavirus because it has an affinity for the human cells. When you think about coronaviruses, and I think about the many lectures we had while in medical school around viruses, the coronavirus was always described as being a virus that had only an affinity for animals. So your pets, for example, when your pet has GI symptoms, your pet has the sniffles or sneezes, that's usually the coronavirus. And the reason why this is called a novel virus, because this particular virus, for whatever reason, has an affinity for the human cell. In fact, it cannot live for more than 3 days without being or integrating inside of the human cell, which makes it very, very interesting. We're learning every single day more and more about this virus, but unfortunately, we don't have the history around it, and it has done what it has done in a short period of time. So this slide is really a salute to Governor Lamont and all of you as employees, because he moved quickly to implement the stay-at-home executive order on March 23rd. I mean, that was just 15 days after our very first confirmed case. So there's something to applaud. And if you look at the other states throughout the nation that are listed here, I mean, for one reason or another, these governors decided to be slow in creating or implementing, I should say, that stay-at-home executive order. And the untoward impacts for that late decision-making will show up. That's a guarantee. As of May 4th, and I pulled this data at the beginning of the week, so we had at that time about 1,500 COVID positive hospitalizations. Clearly, as a physician and one responsible for managing 6 hospitals in New England, I look and I focus on what's happening within the hospital, because it's indicative of what's happening in the community. And so we saw at that time in Fairfield County, we had about 519, or 35% of the hospitalizations to date. In New Haven, we had about 504, and in Hartford, 369, and growing. As a state, we peaked and flattened the curve around the 20th of April. So that's less than a month after our stay-at-home executive order was implemented. And this is great news. And again, I applaud the governor, and I applaud you all for the work that you did. So let me here's the peak. I'm sorry. Oh, the peak. So here's the peak. And this is the flattening that we're talking about of the curve. And I wanted to just highlight that, because it does not mean we're in the clear. It's great news, and it's really great news only for the healthcare systems, because the peak just kind of gives us an idea that we can either at that point bend the curve to create like an upside down V, or flatten the curve to create like an L. Flattening the curve simply means that we were able to control, through things like social distancing, the stay-at-home executive order, the surge of patients or residents that will need medical care. So it's all great news for the hospital. At St. Francis Hospital, one of our hospitals in Hartford, the state was nice enough to give us a mobile hospital. We have not had to use that, and I don't think we will because of the decisions that were made early on by our legislators. So that's great. Now, bending the curve is a total different situation. That's ideally where we want to be. But because the reproduction rate of this virus is as high as it is, we were not able to show the peak and then bend that or create that upside down V. So it doesn't mean that we're going to reduce the number of deaths. And that's a point I just want to drive home. It does not mean we're going to reduce the number of deaths because we flatten the curves. It just means that we're controlling or spreading out over a longer period of time the number of deaths. So here's a slide that I also took at the beginning of the week from the Connecticut, the state website. And what this really shows us is a decline since the 21st of the month, a decline in the inpatient hospitalizations. It's important that, and I chose this one versus a more recent one because I wanted to sort of underscore what happened on the 2nd of this month. We saw a spike, right? So although we had a decline in hospitalizations, we saw at least a 2-day spike. And it makes one wonder, why did we get that spike? Now, it has since gone back down, but it's simple things like summer days that are coming now, these warm temperatures, you see people out in the social distancing and the stay-at-home executive order just is not important anymore. And we saw this spike also because the 12th of last month was Easter. And people left their homes and did whatever they did, but it increased the reproduction rate of the virus. And as a result, we saw that spike. So that's just important to sort of keep in mind. Everything we do is extremely important as it relates to the spread. So here's another from the Connecticut.gov website. Unfortunately, we lost a lot of our beloved neighbors, with the majority of them being ages 50 to 59, which is very, very young as a person who falls in that age group. But here's what's interesting. Remember, the narrative was around two things. It was around 60-plus-year-olds who had comorbidities. And in Connecticut, we're just not seeing that. And then really the crux of today's conversation is that in early March, there was a narrative in the African American community that we were immune to this virus. Yes, immune to this virus. And here we are now having a conversation around how people of color are disproportionately impacted. So let's take a step down into what I call reality. And this is that whole Corona while Black. So I'm sort of playing on the description of driving while Black, which, as you recall, was the racial profiling of people of color that implied that motorists may be stopped by a police officer because of a racial bias rather than a visible violation of a traffic law. Well, today we're experiencing something similar. Now, there's not a person sitting in a car with a piece of equipment that monitors, with eyes that see that they pick out people because they have a higher concentration of melanin in the basal layer of their epidermis. Instead, this is a virus that's invisible to us all. But as we're going to talk about now, I mean, the fundamental system that's been put in place allows this with no car, no detection of your speed. No one has to be there to look at how much melanin you have. And it's doing more damage than a lot of pandemics or epidemics that we've experienced in the past. And that's the problem. So slide 11 is something I got from the Johns Hopkins website. And it published by percent of population and share of coronavirus deaths that looked unfair and disproportionate. And you see Connecticut made the list, which is great. I mean, we are recording it, but there's only 9 on this chart. And why is the question? Where's the rest of the world and why are they not reporting? Well, it's only because it's simple. Only a few jurisdictions publicly report the coronavirus data. And there's a recent conversation coming out of Florida where the governor has sort of laxed expectations, giving the coroner's office the right to not, if they decide not to, even publish it. So as long as we're keeping this a secret, it empowers, I believe, this invisible virus, and the morbidity and mortality, especially of people of color, is going to be record-breaking. This particular slide is exactly what I'm saying, right? So we have to, and I use a medical term, we have to take a myopic approach. We've got to be nearsighted. We've got to drill down into the data. This is from Connecticut.gov, and this state data could suggest that the pandemic is mostly impacting non-persons of color, followed by members of the Latinx community, and then the African American community. So a cursory glance, a hyper myopic glance would say there's not a problem in the Latinx or the African American community. This slide of death shows a similar correlation, which again can be one experiencing a hyperopic view and not really tell the story as it should be. This slide here is more of a myopic view, because if you look at the impact of COVID-19 per 1,000 residents, the sad reality becomes the obvious. You know, if ye shall find the truth and the truth shall set you free, then at some point we as a people, as a group of leaders, we must free our minds of these myths, of this misinterpretation of information and see what's really going on. So this slide shows you how the African American and Latinx communities are suffering disproportionately. And this is the problem. If you just look, the Asian population, 235, this is per 100,000, African American, 930, the white 402, and Hispanic 832. So this should be the front page of the conversation, but for some reason it is not, which is why I think, and there's that scripture that says, seek and ye shall find. So we will have to ask ourselves questions like, why is this happening? And it's not hard to find, right? So it appears as if this COVID-19 has become the perfect storm for people of color. Further research showed that the COVID-19 is hitting people of color much harder. And so there are about 5 points that I sort of want to bring home in this conversation. One is living in crowded houses. So remember, about 80% of the people who are subjected to this virus or test positive either have little to no symptoms, right? So according to CDC guidance or recommendations, many of these people won't even qualify to be tested, if you will. And that's where that racial bias starts to come in, because most of the people who are writing the prescriptions, which you have to have if you're going to be reimbursed by an insurance company for this test, they don't really understand or may not necessarily see the importance or be cognizant of how this group of people are negatively being impacted. So as long as we have living in crowded housing as a normal in these communities, they can't social distance. And if they can't social distance, then they begin to spread the virus at a very high rate. So the reproduction rate right now of COVID-19 is said to be about 2.5 to 3.5, which means that one infected person in this country will spread it to about 2.5 to 3.5 people. Well, that's not a true stat in the communities that house Latino and African American families, because just based on this number one, we're seeing that this reproduction rate, also called an R0, is up in double digits. So one person can spread it to 10, 12, 15 people. And this is not being talked about because the fundamental issue is not being addressed. Number two is working in essential fields. So essential workers are often people who work in food and nutrition, environmental services, and home health care. But they're subjecting themselves. And you ask yourself the question, well, what are the hot spots? Well, the hot spots are the jails and the nursing homes and the meat packing companies, right? So who are these people and how does the virus even get in there? Well, if you think of a nursing home, right, we have a number of seniors that are dying across the country. And the seniors the virus isn't just generating inside of the body of the seniors. There are people who are bringing them into the nursing home and contaminating it with this invisible virus. And that goes back to number two, and it's the fundamentals. Number three is the inconsistent access to healthcare. So oftentimes people of color, as you know, either are uninsured or underinsured. And then something very important as it relates to accessing healthcare, it's having a doctor you can trust. And that's very, very hard to find. You know, many people in the African American and Latinx community, they find a doctor because their doctor is chosen oftentimes by the insurance companies. And it's not necessarily a physician who understands them or their culture, and many times doesn't even literally speak their language. And so that immediately puts people at a disadvantage. And how are they supposed to grow out of such a impoverished environment when you don't even have the trust of the person who is guiding your health? chronic health conditions. Now, let me be clear, right? So people of color are not being disproportionately impacted because of their genetics. That is far from the truth. So we've got to change that narrative and understand it. Now it plays a role, but we'll talk about that in just a second. So I'll stop there. Then stress and immunity, right? So, I mean, COVID-19 is not in the forefront of our thoughts when you are in a community where your neighbor just got murdered the night before. And so things like violence, it's not being coupled in the narrative, in the conversation. So at some point we have to figure out a way to understand and appreciate all that, and then create a narrative or a message that is conducive to these communities understanding it. Of course, the income inequities, discrimination, things of that nature. I mean, if you think about income inequalities for just a second, I mean, when you think about food deserts and food insecurities, I mean, oh my God. So many of these children in these communities depend upon the school system, as an example, to eat at least 2 of their meals per day. And when they're not in the school system, many of them don't eat. We see that during the summer vacation. An untoward event of this pandemic is that a lot of our kids are sitting at home, and they are sitting at home not eating because they don't have access to the nutrition programs in the school systems. And so these are just a few of some important points that we have to consider and keep, I think, in the forefront of the conversation. Why don't we go to the next slide here? I'm just going to drill down a little bit. Let's look a little historically and understand some of the decisions that were made in the past that show up here today. So, this pandemic, oftentimes it's being pointed at the victim, especially the victim of color, and we forget the fundamental reason why these people of color are being disproportionately impacted. So here's what I mean, right? So let's look at redlining. Here's an article I found. It happened to be an article which was funny about the state of Connecticut, right? So the decisions that were made back in the 30s, right? Great Depression. They're showing up now. So shame on us if we point our fingers at this virus and say it's the virus's fault, or the community says it's the community's fault, when the reality is that this virus, to me, is just the creator's opportunity to flash the light, to illuminate the problems that have never been addressed since they were put in place many, many years ago. Here's another example. When we talk about the Highway Act of 1956, so here's a quote I found that's relevant to my hometown, the city of Detroit. There was a section called the Black Bottom. It was called the Black Bottom, not because of the color of the skin, but because of the soil. And it was Paradise Valley was the area where, like many communities, even here in Hartford, back in those days, the post-war era, people of color owned their own barbershops and restaurants and hotels. Some communities even had banks and airports until 1956, that is. And that's when the brilliant leader at that particular time decided to fund highway projects. And then the architects sat down and they decided on where to draw the intersection of these highways. And of course, they chose to put them right in the successful neighborhoods of people of color. Totally disrupted what we had, and quite frankly, we've not recovered since the 50s. So this is just another example of, this underlying, and unapologetically, I will say it, racism through policy that unfortunately has not been reversed. And in some instances, we'll talk about in just a second, it's being perpetuated with new policy. All right, so one of my favorite slides right here. So where you live matters to your health, right? So the truth of the matter is this: healthcare only really impacts about 20% of your longevity, of your lifespan. 20%. Healthcare, 20%. We spend a lot of time talking about the cost of healthcare, which we should be able to reduce, but it's only 20% of the predictor of how long you'll live. Your behaviors are only another 30%, only another 30%. Get that, 30%. Whether you drink alcohol and how much you drink, smoke tobacco, if you exercise or not, your sexual preference, that's only 30% of the story as to determining how long you'll live. The truth of the matter is that the number one predictor of the lifespan of an American is his or her zip code. That's right, his or her zip code, because that's what brings into fact the physical environment and the social economic factors that really determine your lifespan. And until we are mature enough and responsible enough to raise our hands and say, yeah, we get it, redlining and things like the Highway Act really did create the so-called ghettos of people of color. And these are the areas where the pollution isn't the way it isn't being managed appropriately. You put warehouses or industries there that contaminate the soil, so we can't have gardens. The water, and I'm from Michigan, so when you look at Flint, which is a prime example, I mean, how does something like that happen? Well, it happens because it was designed to happen that way, and these are the outcomes, unfortunately, that we're experiencing. So this particular slide it's from the Robert Wood Johnson Foundation, which is a very reputable foundation. This article, and this is not novel information, but they just decided to come out in 2020 and admit to it, that for the first time, and I'm looking at the highlighted section, for the first time in our history, the United States is raising a generation of children who may live sicker and shorter lives than their parents. Wow. I mean, so, you know, what you put into the equation is exactly what you get out. And I applaud the RWJF for bringing this up, because if you look at asthma as one simple example, and the pandemic is just another. I mean, asthmatics in the inner city areas where the redlining started off, I mean, these are today's hotspots for asthma and things like the coronavirus. So here's another. So this really is bringing up the point that essential workers are mostly people of color, and they're being impacted the hardest. And so, as a reminder, again, not a new news story, but at the Tyson Foods plant in Indiana, 900 workers, at least when I pulled this article, when this article was published, 900 workers tied to this one plant tested positive for the coronavirus, 900. And then following that, our president, and I would assume that he wasn't properly briefed, or he was properly briefed and didn't really understand the briefing, but he invoked the Defense Production Act, right? So the Defense Production Act, we know it to be invoked things like during a war, where like the auto industry would be mandated to make equipment or armory for us to defend ourselves accordingly, hence the name. You would think that something like this would have been suggested or even thought about deeply coming from that administration when we had a shortage of ventilators. But that act was implemented only to force these essential workers to go to work so that we won't have a shortage of meat. A shortage of meat. So when lives are less important than beef and pork on our plates, oftentimes which causes coronary artery disease, it's the physician in me, so I have to say it. And that's more important than the lives. And we don't have to worry about a virus, because at some point we find out that we're really already sick as a people. And so this next slide just highlights the fact that 1 out of 5 essential workers don't have the opportunity to work remotely. So they can't telework. And I learned doing some conversations with some of the DCF leaders, which is very interesting to me, what you guys are saying from the kids that are tele-learning, right? And this is the parallel or the antithesis of that. So these workers have to go to work because they can't work from home. And these are mostly people of color. And this is why there are 900 people at that factory that got impacted by the virus. But then the children are at home because of this pandemic, and they can't engage in learning. So you guys see it every single day, and we see it in healthcare. But this is a very, very serious problem that I believe that who much is given, much is expected. And so we, the number of, I think, 70 people on this line as leaders, we have the responsibility to recognize that this is happening and to address it accordingly. So the social determinants of health, again, I call them social influences of health because the word determinant suggests that it's permanent, but it's an influencer because we can all do our part to change it. So childhood experiences, housing, education, social support, family income, employment, the same things that we talked about play a big part. And the sum of everything that we talked about equal the social influences of health. Just a couple more slides here. So I'm at home and getting ready for work last week, and I'm watching a news station that I watch, and the ad council commercial comes on. And so, of course, I had to rewind it because I took a picture of it to make this slide to present it to you. But here's what it said. It said, whether you have COVID-19 or not, stay home. So think about that. Whether you have COVID-19 or not, stay home. So many interpreted that as this, I believe. Whether you have a heart attack, whether you're having a stroke, whether you've got belly pain, nausea, vomiting, the worst headache ever, numbness and tingling in your arms, or even COVID-19, do not come to the hospital. And I'm sure that's not what they intended. But as leaders, we have the responsibility to let them know any unintended consequences that may come from their so-called good efforts, right? I believe they meant well, but alone together, and I can't help but to think about elderly people, right? Elderly people who are unfortunately living at home alone, right? And so we can't celebrate being alone at home. We can't do that because I don't know how you can be alone at home and be together, especially when you see data like this. So this is data, this is real data. This is actual data from Trinity Health in New England, so hospitals, Catholic hospitals that you guys are familiar with. And what I asked our statistician to do was take a snapshot from March 15th to April 15th of 2019 and compare it to the same time in 2020. So compare that 30-day period year over year. And I chose 5 very serious diagnoses. I'm an ER doc, and these are the ones that I think about every time I go to work. I want to make sure I don't miss these. And here's what the data showed. Year over year during that 30-day period, heart attacks decreased by 47.6%. So think about this, right? So the only variable here, ladies and gentlemen, is the coronavirus. And the coronavirus is not cleaning out the arteries in one's heart. It is not happening. So why did heart attacks decrease during the same time period this year because of the coronavirus by 47.6%? Why is heart failure down by over 50%? Why are they over 43% less strokes? Why is the appendix not being infected as much as it has, at least to the degree? It looks like it's 28% less than it did last year. And then gallbladder disease. Why is over half of it not happening anymore? And then I looked at the emergency departments. Why throughout our hospitals, and I'm sure this is true throughout. In fact, I can tell you for the entire state of Connecticut, ED visits have decreased by 43%. But why is that? So what is it about the coronavirus that these things aren't showing up? Is it a good thing? I read an article yesterday where a physician from a state not in Connecticut, thank goodness, suggested that it's because people are less stressed and they're sitting at home eating good when they otherwise would not be, and they're exercising every day. And I don't know what could be further from the truth than that. Because here's the reality of it all. We're seeing people are at home dying. Here's the proof. So, being the person that I am, and I like to get to the truth, because again, the truth it'll liberate our minds from falsehoods. So I picked up the phone. I called a funeral director in California. I called a funeral director in the state of Michigan, and I called a funeral director here in Connecticut. I read an article about the state of New York, and here's what it showed. At-home deaths in New York have increased by over 350% since the pandemic. At-home deaths. In the state of Michigan, 168%. The state of California, 250%. In the state of Connecticut, 166%. So the answer to the question is they're at home dying. And so when you think about conversations like whether you have COVID-19 or not, stay home, while again, that stay-at-home campaign had great intentions, the result is this, and people are dying. And my last slide just shows a little bit more of, I think, things that we need to maintain in our thoughts. So African Americans, and this is just an African American slide, they make up about 6 to 8% of the Connecticut's population. But we see that 25% of our deaths are people, are African Americans. And so that's the disproportionate conversation that we have had and we need to continue to have. Most deaths are males. Most, again, are from 50 to 60. We talked about it hitting the obese population the most, but that is not true. It's mostly overweight, which many of us are. And here's another interesting fact in here. What we're seeing is that almost 20% of the African Americans that die in the hospital, in our hospital, because I only have access to our data, they die in less than 24 hours of arrival to the hospital. So they're not even there a full day. So what that tells me is they're sitting at home, and not until they're literally taking their very last breaths do they get up and come to the hospital, because 19% of them are dying within 24 hours. And we have excellent hospitals. We have some of the highest quality in terms of performance in your state of Connecticut. So it's not us, it's the messaging. It's the situation that had been created back in the early 1900s that is showing up today, masked under this umbrella called COVID-19. 33% die within the first 7 days. When you look at every other race, they're dying after 7 to 14 days. So I don't know what all that means, but what it does mean is that we need to come together as leaders in the state of Connecticut and figure this out, and figure it out fast. And I believe fundamentally we're going to see that it came from the policies of yesterday. And if there is going to be a tomorrow, then we need to act now. Because if not us, then who? And if not here, then where? And if not us, then who? Thank you.
That was unbelievable. And if you are like me, my heart is just pounding. I appreciate this. We are blessed to have you in this conversation and to lead us as we begin to change the future. It is us that needs to change the trajectory of what happens to our kids and families. And we hear a clapping loud. Listen, I know you all must feel the same way that we do. We are now going to be led in a facilitated dialogue through the chat. So please direct your questions, your comments in the chat. And I'm going to ask our Director of Multicultural Affairs, Monica Montalvo-Rams, and our consultant, Jenna Goldstein, to begin the facilitation of the dialogue that's in the chat.
Wow, wow, wow. There's the information that we just received has been not only been alarming, it's been informative, and it's just been very powerful to hear the stats and the information that you shared. So thank you, Dr. Edie, for that wonderful presentation. And so I think I think there was a lot of information that came forth. So I think we'll just take a little moment to let all that sink in, so that we can start seeing some of the questions that we have posed. But like as Jody said, Jody indicated, yes, there's many claps. So many individuals clapping loudly. Our commissioner said, this is our call to action. This data and these stats are alarming, and you just don't get this message anywhere else, from Program Director Latasha Johnson. Our Director of CT Kind, Julie Fleming, has indicated this is a very thought-provoking in terms of housing, i.e. lack of affordable housing in Connecticut, doubling up, overcrowding, couch surfing, etc. We need to consider how this pandemic has impacted the families we serve. How can we improve current housing services and review the gaps in current services? So this is an opportunity for us to really take a moment to think and pause and really do due diligence and looking at our own policies as to how and where we can look at these changes and continue to move the work forward. Let's see if we have any other presentations. Again,
yeah, Monica, I see a few questions coming in, so maybe if we can throw a few questions over to Dr. Edie. I see Maureen has a question about if you have insight, Dr. Edie, on how do we encourage our families to seek medical care earlier? So are there particular things we should be talking about, thinking about in the communities in which we work, which tend to be Black and Brown communities? What do we do in our work to try to bridge some of that you talked about?
Yeah, I'll speak for my family. So, the hospital, one of the things that attracted me to healthcare was, when I saw family members dying at an early age from what I thought to be diseases that were preventable. Many people of brown and Black cultures, they don't have a trust of the healthcare system for reasons that are completely understood, right? But we have to change the way that thinking has perpetuated, right? So people like me have the responsibility to get out to the places of worship. So I need to be invited. I must comb the neighborhoods and represent healthcare to create some degree of security amongst people of color, right? We have created this fear about coming into the hospital since the pandemic started. When the reality of it all is the hospital is probably the safest place to be because we have done an excellent job around controlling this infectious disease. So I think education is number one. I think adequate and proper communication, like the way that they need to hear and understand it, that has to be considered, and that has to be delivered, and that has to happen right away.
Thank you, Dr. Eady. We have another question posed. What do you see as our top priorities that we can do in our day-to-day work to change these alarming minority statistics?
Yeah, so I think we have to we have to have more we have to have difficult conversations. And no one wants to talk about things that happened, in the early 1900s, right? No one wants to talk about that. And look, we don't even have to go all the way back to things like slavery. We can just go to yesterday. And when we start talking about that, and we have to have the audacity to do it. When we start talking about that, then we need to mature those conversations around our policymakers, right? And then we need to go out and vote for people who give ear to what we're feeling and how we're feeling and what we need. And so it'll take a whole community to make the change. But if not, you're going to still see things coming out of Washington, D.C., like the people who work in meatpacking companies do. And what chance do they have, right? 80% of them may be just fine, but the 20%, most of them are going to end up on a ventilator and die. And so, and remember the reproduction rate of them. So those 900 people will infect another at least 2.5 to 3 more people. So this is a huge problem. But look, the pandemic is going to go away. It's going to go away. Now, there's going to be another airborne virus, but there's going to be multiple other things other than airborne viruses that if we don't address the crux of the matter, and that are things like the social determinants of health, if we don't make zip codes not reflect or be the number one determining factor of how long you live, then what are we here for?
Thank you. We also have a comment. If you can talk a little bit more about the myth regarding Black people being immune starts and related to other healthcare myths that circulate in Black communities that impact people seeking healthcare.
Yeah, sure. So I think it was twofold. When I went to the Johns Hopkins website and you saw from a global perspective that it was in northern countries or continents, and you looked at Africa in between those continents in the US, it was just not in Africa. I mean, it's very small circles and a few number of circles, whereas you had multiple circles, particularly on the East Coast of this country, and you had multiple and large circles in Europe, for example. Clearly in China, where the genesis of it is, you can trace it to travel. But clearly, a lot of people weren't traveling to Africa during this time period, at least since the middle of last year. And then you can see it move from the East Coast of the United States. And as it moved, the numbers just did not show African Americans or people of color being impacted disproportionately. So it led to this unbelief that people of color were immune from it. And so we sort of banged our chest and said, look at us, finally we have something to be proud of. But then just weeks later, the truth came out. And in urban environments, as you guys saw, Black and brown people were dying at a high rate and continue to die at a high rate. And so I believe that's where it started, but it got quickly dismissed, unfortunately. And now we're having this conversation. So how could we, in retrospect, have not allowed these communities to become so comfortable and misled? Like, how could we have prevented that? And I don't know. I'm thinking about it, but I promise you, the next time we see something like that, if I'm alive and can help it, I'll do the best I can to try to create these kind of conversations to ensure that we don't make the mistakes that we did as a people.
Thank you. So we appreciate the time that you shared with us this morning. For the essence of time, we're just going to keep things moving forward. If those of you that still have questions to be asked, please write it into the chat. We are going to be formulating and taking all of the comments and questions and hopefully getting a different a document for you to provide your the responses to your questions in a bit more deeper format. So please continue the dialogue in the chat, but we will continue to move forward. Again, thank you, Dr. Eady, for your time and your presentation.
My pleasure.
And we take it back to.
Yeah. Sorry about that. That was amazing. That was absolutely amazing. And Dr. Eady, you cannot see the chat below.
It looks like she may have frozen.
So go ahead and pick it up, Monica.
All right, so it looks like Jody has lost connection, so we will continue to move forward. I'm sure her sentiments were very similar to those that we just expressed and how grateful we are for having Dr. Eady with us here at this time. Right now, I'm going to kick it back to our commissioner, who will talk a little bit about the application to practice and what it means for us in child welfare.
Thank you, Monica. And Dr. Eady, it's hard to follow you because not only are the statistics sobering, but it's an illumination of the fact that the work that we do is head work and heart work. That if you hear this information and you are not affected by that, then maybe human services is not necessarily the field of practice that you should be in. But all of you, particularly those of you that are on this call, have committed your lives to leading this work and to leading change across communities in Connecticut. And so what we are at the point right now in our conversation is, how do you take information, transform it into strategies that will help us move forward as a collective child welfare system? And as we think about the information that Dr. Eady just shared, how do we as a child welfare system move beyond hearing the information and doing something about it? We recognize that at DCF, sometimes some of the outcomes that plague the children and families that we are involved with, we are not solely responsible for. However, we have taken up the responsibility of making sure that the sphere of influence we do have is impacted by the direct actions that we take in our practice and in our work with kids, families, and communities. So right now we are at the point in our program at which we will turn the slides over to Susan Smith, who will step us through some of our DCF Connecticut data.
Okay, can everyone see the slides and hear me?
Yes, we can. Thanks, Susan.
Okay. All right. Thank you, Commissioner. I appreciate the introduction. And you kind of took the words out of my mouth. I was a little daunted to be following Dr. Eady, and I never understand why everyone always puts me after these really accomplished speakers with such important and clear and call messages. So be prepared to be underwhelmed and mildly disappointed. When we realized that the COVID-19 really was not a test, not a drill, and we really were at DEFCON 1, we immediately started to engage our data. I think for all the reasons that Dr. Eady outlined, we knew and know that our communities of color in quote unquote kind of normal times are impacted by a variety of issues that result in disparity and disproportionality. And it seemed, quite endemic that something such as a global pandemic might also result in more disparate outcomes for our families of color. So we really started to approach this almost kind of epidemiologically and from a public health kind of a way of trying to think about how do we kind of get ahead of this? How do we really think about where some of the issues are and how might we marshal some of our resources. Sorry, the slides are acting a little wonky right now. Okay, and how we might marshal some of our resources in order to make sure that we're aligned in terms of areas where we might see some impact. So we started just really thinking about the pathway. I didn't bring a copy of that, which is probably the first time ever that I didn't actually bring a copy of the pathway, but I think folks are familiar with that, and really started to try to unpack some of those decision points to start to see, are there things that are revealing of some potential areas where we need to really be thinking about where support might be needed, or where we might be trying to get ahead of some areas where we might see some disparate impact and some increases in some poor outcomes. So we started, looking at our calls received, and as folks can see, that there's been a precipitous drop since around March 15th, March 16th, and that aligns with the executive order for the closure of schools. Kind of disregard the 2018 data, that's a little anomalous, but if you look at the 2019-2020 data, so for that first part of the year, you'll see that the trend lines are very similar for 2019 and 2020. But then at that point where we went into our kind of quarantining and staying at home, sheltering at home order, we really saw that those calls have significantly decreased. We also looked at these calls, the accepted calls by race and ethnicity, and we're finding that for families of color as well as for our Caucasian families, that same trend and that same pattern is holding in terms of accepted calls. What's actually kind of interesting, though, is that while for all races we are seeing a clear decrease in accepted calls, congruent with obviously the rate of calls that we're receiving, the distribution is actually a little bit different for our families of color. So, we often have those conversations about kind of the gate into the pathways, and so we are actually seeing as a percentage, as a distribution for our families of color, actually kind of a little bit lower percentage than in previous years. So if we looked comparatively at these data for the same period of time for 2019, the percentage of accepted calls for African American and Hispanic families was higher last year this time than it was than it is for this year, but a little bit higher actually for Caucasian families. And so again, just some things for us to start to maybe think a little bit about. I really want to also kind of add a caveat, is that we're talking about a fairly compressed period of time. So there are a lot of things, there's still a lot of questions in my mind in terms of kind of what these data may tell us definitively. I think it's too premature to kind of use these in terms of saying, yes, aha, we know exactly what's going on. But I think that they do certainly offer us a great opportunity for us to really be thinking about our work and our practice and where do we go under the rubric of kind of a new normal. So some of these, the ends are a little bit small, and again, we're really talking about a 5 or 6 week period. So there is, obviously some caution that I like to attach to these numbers and these data as we take a look at them. We also looked at the reporter type, and not surprisingly, with the closure of schools, the distribution of caller type has also changed. And majority, as you can kind of see from the purple bars on the far left-hand side, earlier and even in 2020, schools and daycares were the majority categories of reporter type. And we've seen that since, again, with the school closures, that has changed. That's now been more police, hospitals, and then school and daycare have in turn kind of moved, demoted to kind of the third position in terms of the the distribution of reporter type. We also just took a look at reporter race and ethnicity to just kind of get a sense of, is there anything there that's starting to percolate. We do see actually a decrease in the percentage points of reporter types being identified as white Caucasian, which certainly could be related to some of the reductions from the school category. We see slight upticks for reporters who are identified as Black or Hispanic. and also slight upticks under the unknown category, which could also correlate with whether or not we're seeing fewer kind of mandated reporters. We could be, it could also fall into other categories that we, obviously aren't quite aware of. But we do see slight differences here in terms of reporter type, which again makes me think a little bit about kind of our pathways and some of the conversations that we've had about kind of who comes to our attention and by whom. We also started to look at the allegations that have come in and just looking at medical neglect, physical neglect, and physical abuse and sexual abuse. We've seen, for example, with the medical neglect, that there are some reductions for our Black, Hispanic, and white families, but with the actual decrease for medical neglect allegations for white families. And I think this is, again, is one of those categories that's actually really interesting. And I think about the slide that Dr. Edie presented in terms of some of the changes in the presentations in the hospitals and the ER, and it makes me think a little bit also about kind of what this potentially means in terms of medical neglect. And then obviously with some of the changes with access to kind of healthcare and potentially telehealth, has that impacted people's ability and people reporting of this? Is there really actually kind of been a change in medical neglect, or has it been obfuscated a bit in terms of some of the messaging in terms of staying at home and not perhaps having the same ability and access to health, to physical presence in terms of a physician. Also in terms of physical neglect, while it's been fairly kind of stable in terms of a percentage, so again, what we're looking at here is we're looking at the percentages in comparison to the same period a year ago. So that percentage has remained kind of fairly stable in terms of the allegation type coming in, but there's been a slight decrease though for Hispanic families, which is actually going to be something a little interesting when we get to the area of substantiation. Physical abuse, seeing slight increases for our Black and our white families, but a decrease for our Hispanic families. Sexual abuse, small decrease for our Black families, but we are seeing some increases for our Hispanic and white families. I particularly illuminated the educational allegation piece because I find that actually quite fascinating. I'm going to kind of start with the piece where we are seeing that for our Hispanic and for our white families in particular, that the comparison of education neglect allegations in comparison to the previous year is actually higher. So as I recall, is that for Hispanic families, they were about 32 or 33 or so % of the educational neglect allegations, but now it's about 39%. For white families, pretty similar. I think it was about 34, 35, and now is also about 39%. So are seeing actually more educational neglect allegations for Hispanic and white populations. But then when we look at our Black families, who were about 22 or so % of the educational neglect allegations last year, we're seeing now it has decreased to 6.1%. So a huge drop there. And, there's so many things. I think, you can almost, talk, about this, by itself in the course of a webinar like this. But I think it's definitely an area for us to think a little bit about and maybe to try to unpack a little bit more. And again, I'm going to sound a little bit like a broken record, is that as these, data are still within a pretty short period of time, there are still some things that we really can't necessarily know from them. But I think as we start to continue to review this and assess these data cumulatively, there may be some things that we'll really want to unpack here and really think about what the conversation may need to be internally in terms of practice and how educational neglect perhaps is framed within a rubric of prevention, some of the conversations that we have with folks in the community. But I think it's really quite interesting. Also, thinking about it in relationship to some articles that some of you I think probably have also seen, where there are parents and often parents of means who are talking about the homeschooling is overwhelming. I have other things, and I'm just opting out, which I find a little kind of humorous to some degree in this concept of being able to kind of opt out of something that's kind of compulsory and certainly not to detract and recognizing how challenging the homeschooling is for folks. But I just think about it in the context of our families and in a light of kind of relativism, is that when thinking about all the stressors that they have, thinking about some of the resource challenges and some of the issues that they may have in their households, and some of the things that may impact their ability in quote unquote kind of normal times to get their kids to school. So it's just something to think a little bit about. And again, I also want to throw out is that, it's not in negation into any way to obfuscate, obviously some of the seriousness and some of the issues that we've unearthed with educational neglect allegations that, we've had some, cases that have had not so great outcomes that have come to us under educational neglect rubric. So it's not in any way to, to depress or demote that, but it's just, again, to think a little bit about some of these concepts. The majority of our substantiations are coming in as physical neglect on some level, which isn't really surprising to me, and particularly under the rubric of COVID, it kind of seems to make some sense. When we look at the physical neglect substantiations by race and ethnicity, we are seeing that for families who are multiracial other, we're seeing a little difference from this year as opposed to last year the same time. And for our Hispanic families, we are seeing a pretty good difference from this year as opposed to last year in terms of the majority of their substantiations being for physical neglect. And I think that's really kind of an important concept when we start to think about the various impacts of COVID. I threw in here, and this is actually a hyperlink, so when folks get a copy of the PowerPoint, you're actually able to click to the article. Is from Forbes magazine. It really talks about the economic impact of COVID and how it will potentially be hitting minority families the hardest. And it also made me kind of think a little bit about some of our families who may be undocumented and whether, kind of what we're seeing now may be a harbinger of some things that may be coming more apparent in the future. Thinking about some of our undocumented families, who may have been, working, employed, paying taxes, but now may be unemployed or underemployed and may also not be eligible for some of the federal cash assistance resources if they're undocumented. If I'm not mistaken, I don't believe that they're eligible for the stimulus. So those are all things that obviously could impact people's economic stability and potentially could have some interconnectedness to physical neglect allegations and also potentially physical neglect substantiations. And when we look at the kind of overall substantiation, so looking at all the various allegation types and overall substantiation rates, we do see a little bit of an uptick for Hispanic families as well as for families who are identified as multiracial and others. So again, just a couple of areas that I think we need to be thinking about, and also being aware of how COVID may also potentially impact these data as we continue to review them. Also,
Susan, I'm
yes.
sorry. What we're going to do is take a pause. That is absolutely incredible. We can see the chat going crazy here. And in the interest of time, what I'd like to do is to let everyone know that this is a teaser of the information that we have. And I would like for you to just quickly go through these slides so we can get to the questions because we're running out of time. But as you can see, this information is absolutely amazing and thought-provoking. And also, as the commissioner said, and I think you alluded to, we're very early in this conversation, and this is meant to be thought-provoking and thought-provoking only.
Thank you.
So
thank you, Judge.
Finish that up in just the next 30 seconds, and we'll get to the questions so that we can.
So I'll do super quick. So substance use and IPV, taking a look at those. IPV, very similar to what we're seeing nationally, uptick in that for most races and overall. When we look at children placement in terms of their settings, that our CIP in general has been decreasing, which is a good thing. We've also noted some increase in our children of color being placed with relatives, which has implications for our resources. We are using trial home visits much more now than we had in the past. I also would importune folks to keep an eye on runaways, particularly for our children of color. So that has potential implications. Kind of shout out, we're seeing a lot of stability in terms of placement. As you can see, these numbers are phenomenal. So whatever we're doing in that arena, whatever kind of outreach and support we're doing, we need to keep that up because we are seeing tremendous differences in terms of the rates of permanency and placement moves. And so, obviously, these are a variety of places and areas and impacts and outcomes that we're going to continue to take a look at, and to make sure that we can kind of get ahead of some of this. Some of the things we're seeing, length of stay for our children of color, and is actually increasing a little bit. So we'll obviously want to keep an eye on some of that. Not seeing a lot of changes in terms of the nature of fatalities at this juncture. A lot of unsafe sleeping, so very similar to what we've seen, but certainly an area we want to keep an eye on. And then obviously just really thinking about, as Jody alluded to as the commissioner, and Dr. Eady is really thinking about the interconnectedness of all these data, and really the opportunities they potentially also bring, not to negate the challenges, but also the opportunities to think about how do we refine our practice or policy, thinking about how we enhance prevention, and also areas for intersection with partners and collaboration.
Amazing. Who says that's underwhelming? That's a lot to keep up with. The one and only Susan Smith. I mean, again, this is data that I think is going to be the springboard for conversations to come. We have to start watching this data so that we can change the trajectory and create the narrative that we know needs to be said in the state of Connecticut. Susan, you did a fantastic job. Thank you so much.
Thank you.
We're gonna have, in the interest of time, have Jenna Ghosty kick off what this presentation, the data, your questions regarding the data. Susan, I'm sorry, Jen, if you could unmute, and we're gonna have, after Jen, a facilitated dialogue between Susan Riley and Monica Montalvo-Rams.
Thanks, Jody. And I will be quick. So first of all, underwhelming is a word that never comes to mind with Susan Smith ever. And what I wanted to do in some ways is echo something that I even saw that the commissioner posted in the chat, which is there were a number of comments, questions about sharing the data and feeling this urgency that all of us have, because if we see this, you can't unsee it and you want to shout it from the rooftops, right, to bring others in. But we were very purposeful in having this data follow Dr. Eady's presentation, because this data is part of the story, but it's Dr. Eady's presentation that really draws that straight line between this notion that every system is perfectly designed to achieve exactly the results that it gets. And, in the spirit of all the work I think we've done collectively around this, we have to just be very mindful that we can't, if we show these data to many people, they quickly run to draw their own conclusions. And what we really need to have happen, if we're going to enter into conversations that lead to action, that lead to planning and response, that ultimately dismantle the system we have for the system that we all want, we have to marry it with that kind of information that Dr. Eady presented as our foundation in our context. So as we're seeing a lot of conversation and questions, I want to invite this next question, and for all of us, as Jody said, it was the teaser. This is today, is the inspire you so that you can't unsee it and you feel moved to action, to really then marry these two pieces of our DCF data with all of what we just heard from Dr. Eady, and figure out what is the message, what is the narrative that we're taking forward, how are we taking the messages that when we all get our local data, we have a story not just to tell, but we have asks and invitations for partnership. With that, again, let me turn it over to Monica and Susan to ask a few of these questions that have been posed by the group. And then for all of us, I invite you to spend these last sort of 13 minutes to start thinking about the chair in which you sit. What do you do? How do you take this not just to ruminate on today and to think through over the weekend, but to really focus on what are our collective next steps, so that this isn't the same narrative in 2 months if we have a second wave, or in 5 months if we have a third wave. To Dr. Eady's points, in 2 years when we have something else, not a pandemic, but something else, so that we're not just having the same webinar over and over, inspiring us to action, but that it actually moves us in that way. So Monica, I'm going to turn it back to you.
Actually, I believe Monica might have gotten kicked off. So Susan Riley?
She might have. So she's having a hard time seeing the questions. So I know we only have a few minutes, so I want to draw a connection between what's going on in the chat and what Jen just said, which is lots of people want to share these data. I think both the data in Dr. Eady's presentation and the DCF data. And so I was struck, Susan, one of the things that you said was the need to unpack this further and not to leap to conclusions. So I'm wondering if you do have some thoughts that would relate back to everybody wanting to share it about how to unpack it further. What are the other things that we want to look at, and what kinds of early hypotheses do you have in order to follow the data?
Not a hard question, Susan. So I think thinking about some of our qualitative data is also going to be important. So some of the data from the PIP process as well as ACR, I think that those data pieces are also really critical for discussion. So also, obviously what folks in the regions are seeing, I think that those are critical pieces for us to really understand this. I think what we know is that, no matter what kind of where the data tell us now is that we can't look at this ahistorically and acontextually. So we know that, historically our families of color are often overrepresented, and there just may be things that we need to be kind of aware of to really be mindful of that. So even if there are some things that kind of look quote unquote good, I think we need to be careful about that. And it's not to say that there aren't perhaps some things that also could be really good lessons for us to think a little bit differently about how we approach certain things, but we also don't want to become, potentially complacent, and potentially miss some really important things that we could potentially be doing in order to better support our families. So, again, there are some things that may be, may kind of shake out, so with our family, folks are getting the stimulus checks, we might see some differences in the substance use data. And we also know that substance use often doesn't present itself to some extent until we've had longer engagements with families. So some of those data that we saw from the previous year, where we've been working with a family and we've updated those fields in LINK, may be reflective of that. So that data in particular may not really be reflective of what we're seeing. So obviously to be careful about it and to kind of trust your professional judgment when you're looking at this and thinking about all the work that we've done in the past, and which has really kind of reified for us what we know exists related to disproportionality and disparity, and to kind of always kind of keep that in the back of your mind as we're unpacking this.
Great, thank you. Jody, I want to check in. I know we've only got, there's Monica, 8 or 9 minutes. So do we have time for a few more comments, or do we need to switch over back to the commissioner at this point?
So, Jody, you're on mute.
Thank you. I think we're going to switch over so we can go to our end. And absolutely amazing, Susan Smith, as usual. This data is very thought-provoking. And as the commissioner alluded to, Monica, I'm gonna have you bring back up the other slides. As the commissioner alluded to, it is the head and heart conversation. And we didn't want to just have that powerful conversation with Dr. Edie just stay there. We wanted to bring it to what we should be doing next as a department. And so what we're asking for you all to do is to take this information, share it with those who report up to you. We are hoping to do this again because we had far more people interested in participating in this webinar than was able to. So consider yourselves the chosen. And we chose you because you are the leaders of this department, and we need you to carry this information forward. And so with that, we are going to ask that you begin those conversations again with the people who you report to. There's a story that's not being told, and we didn't want you not to know what's happening outside of what's being reported. Many of us have been privy to conversations, or we even have experiences ourselves. Have lost loved ones. As Dr. Edie alluded, my brother is a funeral director, and he's seeing firsthand how people are being removed from their homes. And so education, our young people, as I talk to my own children about COVID-19, our young children really need to be educated on this. And as we go out and talk to the kids and the families that are served by our department, we want to educate them so that we can change the trajectory of the numbers, making sure that we are supporting our communities of color. So with this, we have a lot of Monica, I don't see the presentation, just so you know.
Oh.
Yeah, so we have a lot planned as it relates to this discussion. This is the first of many, as we said. we have couched our racial justice work in what we're calling the culture of safety that we are going to unveil in the weeks to come. So we're excited to present that that format to you. Thank you. You can advance to the next slide. We are excited to unveil this. We are naming our culture of safety safe and sound. We believe that in order to have an adequate conversation and productive conversation about race, we have to create the environment for you to have these discussions honestly. We need to be bold in our conversations, and we need to be honest about what we're seeing and what we need to do as leadership and as staff of DCF. So look forward to this unveiling of Safe and Sound, which will include our racial justice work. And we're looking for leaders, those of you on the call, to engage in what we're naming the 5 R's. It's to regulate, relate, rise, reason, and respond, and do something different. I want to extend a sincere appreciation to Dr. Edie. You were absolutely phenomenal, just what we needed to start this conversation. We look forward to future conversations with you. We'd also like to thank again Susan Smith. You were absolutely superb in grounding us in what we could do differently here in our practice. I'd like to give a major shout out to Jenna Ghosty and Monica Montalvo. They were hands down responsible for putting this all together, dealing with all the logistics. I am the senior executive lead for the racial justice work, but these are the people who do the work. I'd also like to acknowledge Tina Jefferson, who is one of the tri-chairs of the racial justice work. She has been phenomenal in leading the state in this conversation. And so without further ado, I'd like to turn this over to our commissioner, Vanessa Durantes, for closing remarks. And thank you all for joining us.
Wow, so I hope that over the last hour and a half, you guys have reflected on the information that was shared. I see a lot of your wheels turning already about the things that you can do and take away from the information that has been imparted on us today. As I indicated in my opening comments, that the DCF Statewide Racial Justice Work Group is one of the leaders in this work in child welfare across the country, and we will continue to elevate the information that you heard here today, not only in the work of the department, but across with our partners and other stakeholders across the state. I thank you, Dr. Edie. I thank you, Susan Smith, and our Statewide Racial Justice Work Group. Thank you, Jody. Thank you, our partners at Casey Family Programs, for helping to facilitate some of this conversation today. And I thank all of you as leaders across the department who continue to help us elevate race as a contextual factor for the work that we do with kids and families in a child protective world. The color of COVID in Connecticut is a call to action. And as Dr. Edie indicated, we must answer. So have a good day, continue to socially distance, and continue to do this work.